Okay, so that's in the United States our first mental health hospital. By 1880, Dorothea Dix was able to advocate, and there were 110 psych hospitals within the United States. 1946, we have President Truman. President Truman establishes the National Mental Health Act, which establishes the National Institute of Mental Health. Now we have research dollars. Now we can begin to understand mental health. That's a really big deal. We can research what's the best, how do we diagnose, what's the best way to diagnose. We can research what's the best treatments. Really big deal. 1955, the number of mentally ill people in public psych hospitals peaks at 560,000. 1963, a new act is signed. This is the start of deinstitutionalization. President Kennedy signs the Community Mental Health Act. The goal of this is to provide federal funding for community-based preventive care services. Great initiative. Problem is, there was the Vietnam War and the economic crisis. So this initiative never got funded. The act was made, but the funding never came through for it. Then things really began to shift. 1965, Medicaid passes. Why is that so important? Because Medicaid excludes funding for people in institutions of mental disease. Now, we already said people who are mentally ill are more likely to be in poverty. People in poverty are people on Medicaid. So now people who are in poverty have a health insurance that will not pay for mental health institutions. This is how we start closing the door to mental health institutions. We say, we can't admit you here. We don't accept your insurance. Okay? In 1977, there are 650 community health facilities serving 1.9 million people. 1980, President Carter signs another act, the Mental Health Systems Act. This was very similar to the Community Mental Health Act, to try to get it going again. Try to make a community-based structure for preventative mental health care. But a year later, President Reagan signs the omnibus budget. That blocks the funding for Carter's mental health systems budget. So again, we have the act, we have the intention, but we don't have any funding. It just keeps getting worse. 1985, federal funding drops to 11% for community mental health agencies. 1996 starts getting a little bit better. Here's where the Mental Health Parity Act is enabled. This means we have to treat health insurance, or we have to treat mental health disorders the same as other health disorders. But the one in 96 had a lot of rules and regulations behind it, so it wasn't super effective. Wasn't until 2008 that the Mental Health Parity and Addiction Equality Act is passed, further expanding parity requirements on all health insurance companies. So 2008, we finally have equal treatment for mental health and physical health. But notice what never got funded again. We were never able to develop those community-based programs. So what happened, and I'm not going to go through all of this, but what happened is that we continued to close mental health institution doors. So we did the first part. The first part was to get the people out of the hospital. We did that. The second part was to deter admissions into the hospital for the mentally ill. We did that through the creation of Medicaid. But we never did the third part. We never did the part that was replacing the services. We never were able to create an infrastructure in our society for community management. So what happened as a result is that by 2010, there's 43,000 psych beds in all of the United States. Do you know how hard it is to get a psych bed for a patient? It is hard. And that's why what we find more and more is that we have psych patients on med-surg floors. Because there is no psych beds available. Even if their insurance would pay for it, they don't exist anymore. So we are stuck in this problem now where we went and we moved away from hospital-based care for mental illness with the aim of going to community-based care, but we never created the community-based care. So this is just going back really quickly. What is mental health parity? That means that you're going to have equal treatment of mental health disorders as you would physical disorders. So if you need to see a psychiatrist or a psychologist twice a week, insurance can't stop you. So deinstitutionalization, going back to this, there are three parts. The release of these individuals from hospitals into communities. We did that. The diversion from hospital admissions. We did that. The development of alternative community services. We did not do that. So what that means is that the mentally ill have no home in our health system. The mentally ill do not have a home where they can receive adequate treatment within our existing health system. In the few places where we have been able to institute strong community-based mental health programs, the outcomes have been fantastic. What types of communities do you think those are? I heard it somewhere.
Rich ones.
Rich ones. Communities with money. In communities with money, we were able to create these, and it was a very successful program because we had the community base. We had the community-based programs. But in the majority of America, we weren't able to create this. So as a result, what happened to the mentally ill population? Because they're no longer in the hospital. So they're either homeless, they're incarcerated, or they're providing huge challenges to our health system. Because like I said before, it's not uncommon to have a couple of psych patients on a med-surg unit just because we can't find any other place to send them. But it's not safe to discharge them. So as a result of the fact that we didn't follow through on the deinstitutionalization, our mentally ill are homeless and are incarcerated. So some lessons learned from deinstitutionalization. First of all, we have to tailor our programming to the individual. Second, hospitals have to be available for those who need it. We need more than 43,000 beds in the United States for mental health. Third, services must be culturally relevant. If it's not culturally, if I built the best community-based mental health system that money could buy, but it was not culturally acceptable, is anyone going to go? No. Fourth, we learned that patients and families have to be involved in their planning. We can't say, here's your goal. We have to say, what is your goal and how do we help you get to that? And the last is huge. Continuity of care has to be achieved. Especially with mental health, especially if you're dealing with things like PTSD, if you're dealing with traumas, if you're dealing with things like that. They can't relive it every single time they meet a new healthcare provider. So we have to have continuity of care. So now we're going to look at community-based interventions for those with mental health disorders and look at primary prevention. So primary prevention. We need to promote, so now, right now, primary prevention, we're trying to keep a population healthy, right? That's what primary prevention is. We're trying to keep our population healthy before any type of mental health disorder develops. So the first thing we want to work on across the board is coping mechanisms. This is something I'm working on at Widener with my freshmen. Coping mechanisms. How do you survive the first year of college? Okay? Why am I doing that? I'm trying to prevent the midterm breakdown. Okay? So one of the things you do for primary prevention developing coping skills. You identify sources of stress, and you make plans around those stresses to help eliminate or minimize them. Can you eliminate all stress in life? No, you can't eliminate all stress in life. So you have to find ways to minimize them. How do you not let it have a huge hit on you? You want to refer people who are experiencing stress to a support group. Now, I'm not saying that you say to someone, oh, you're stressed, let's refer you to an anxiety support group. That's not what I'm saying. What I'm saying is you say to a mother, seems like you're really stressed with having these 3 busy ones around, why don't you go to a mother-child interaction day? Something like that. I forget what they're called. Like a mother support group. Doesn't have to be associated with a mental health disease. Just get them involved in support groups in their community so that they can see they're not alone in it. Assist clients and families to expand social support networks. It's the same thing, identifying, saying here's where mother groups meet, here's where kids play basketball if you've got a child who's very isolated and is new to the community. Here's where basketball pickup games are. Help them introduce things to that. This is the unique role of the population health nurse. We know the community. So we can tell them where the pickup basketball game is. That's really hard to do from the hospital. Develop healthy communication and interaction patterns among family. Make of their home a safe spot. So that when someone has a really crappy day, they can go home and be like, look, I've had this really crappy day, let me tell you about it. Without any judgment, without any fear of rejection. Create that skill set of communication. Educate clients regarding the effects of illegal psychotropic drugs. So educate patients about the dangers of self-medicating. Address cultural stigma. It's really hard to address cultural stigma once someone's been diagnosed with something. So you have to normalize it before there's any issue so that if it does develop, you say, look, this is what we talked about. This is not abnormal. Everyone can get through this. So you have to address the stigma associated with mental health disorders. What can we do at the community level? We can build supportive communities. This is what I was talking about when I was saying that when we recognize that most chronic mental health illnesses start by the age of 14. Build that supportive community. Make sure that teachers know. Make sure that coaches know. Make sure that Boy Scout, Girl Scouts leaders know. Make sure people know how to have a safe and effective community for those around them. Teach them those skills. Teach them those communication skills. Teach them those supportive skills. Teach them basic things like how to listen. Teach them basic things like how to ask open-ended questions. Make sure they have adequate living conditions. One of the big things we do as home health nurses is make referrals to community organizations. So if someone doesn't have electricity, know who to refer them to. If someone doesn't have running water, know how to refer them to. Because let me tell you, someone can work hard all day, but if they come home to no heat, to no running water, what does that do for their mental psyche? It's not very good. So we need to make sure that they have a safe living condition. We need to make sure that they're, again, it's compassionate environment supportive of mental health illnesses. And we need to know and make referrals for resilience resources within communities. That's resources for childcare, resources for healthcare, resources for housing, education, job training, employment, recreation. But what if they're not there? So these are the things that we want to be referring them to, but some communities don't have these available. And that makes it a much larger policy issue. Okay? At the population level, so this is the level we go to when those programs aren't available for referral. At the population level, we can initiate suicide prevention programs. Who watched the Grammys? Anyone have time for that? Got a few people here. There was one song being played. I didn't know anything about the song, but it's like 1888 something something something, and it's literally the suicide prevention hotline. Okay. Am I destroying it? But no, it's literally the suicide prevention hotline. That was a great initiative for being able to get that number across. Okay. Looking at, we can do interventions to prevent postpartum depression, normalizing it, making it okay. We can engage in campaigns to change public perception of good parents. This is a big one. With social media and everything, if you look online, it's going to be like, and then I sent my child to school with the perfect star-shaped peanut butter and jelly sandwich. And then I did this, and then I did that. And other parents are like, I wish I could buy my kid peanut butter. Okay? So one of the things we need to be doing at a population level is what does it mean to be a good parent? And eliminating these false ideas of what it means to be a good parent. You don't have to be the perfect parent. Advocate for and create home visiting programs for all mothers. Advocate for societal conditions that minimize stress and prevent mental illness, so our safety net programs. And then identify and develop strategies to address existing sources of stress for community members. We can also make sure we're reorienting health services to address mental health needs. This is what I was talking about earlier with the simple question of, have you felt down in the last 2 weeks? Reduce the stigma associated with mental health. So whether it's you're talking to teenagers, maybe identify some teenage idols that have dealt with mental health issues in their past, but find ways to reduce that stigma. Have health-enhancing public policies related to employment and anti-discrimination, and improve public awareness of the availability of effective treatment. For secondary characteristics, secondary prevention, we need to help clients find appropriate diagnostic and treatment systems, services. We also want them to be knowledgeable about and alert to signs and symptoms of mental illness, not just for themselves, but for their entire community around them. Secondary prevention population, just that. Educate the general population regarding signs and symptoms of mental illness. And then tertiary prevention. I'm not going to spend a ton of time on this because this is what you did last semester. Tertiary prevention, before you can be considered for tertiary prevention, you have to meet clinical guidelines for diagnosis and treatment, and that comes from the DSM manual, so the Diagnostic and Statistical Manual of Mental Health Disorders. This is based on underlying vulnerabilities as well as symptom characteristics. At the individual level, what can we do at the individual tertiary level? We can do pharmacotherapy. We can do individual or group therapies. We can do family interventions, self-help groups. We can promote health in clients with existing mental health problems. So these are all things we can do once the mental health diagnosis has been made, trying to get them back to their normal. When we're looking at evaluation of their mental health status, we're going to look at the psych history. We're going to look at the current use of psychotropic drugs. We're going to look at the presence of suicidal ideation or suicide attempts, drug and alcohol use, history of sex offenses, victimization or violence, seeing if they're at risk for PTSD. So these are all things that we want to evaluate when we have someone who's been diagnosed with a mental health disorder. Another thing that's super important is, are they motivated for treatment? We can diagnose all we want, but like I said, the treatment plan has to involve both the individual and ideally the family on board. So we want to look for their perceptions of how bad is their mental health problems. They don't think they're that bad. They think it's normal to only want to get out of bed 2 days a week. Then we've got an issue. We want to look for their desire for and their perceived importance of treatment. This is true for all disease processes. There's a lot of people out there who don't take their cholesterol medication because they don't see cholesterol as a concern because they feel fine. Same thing with mental health. Just because they have the diagnosis doesn't mean they're going to follow through on the treatment. So our patient education has to be on game. And we also want to assess their past attempts at treatments and how they went. In terms of families at tertiary prevention, we want to educate families in addition to the patients about the disease and about how to become involved in the treatment process. We want to encourage them to get support. Because like we said, the burden is high on family members caring for those with serious mental illness. So we need to make sure that they have an outlet as well, or they will eventually develop mental illness issues as well. We need to make sure they have realistic expectations. Am I going to be able to cure your schizophrenic son? No. But am I going to try to make him as functional as possible in society? Yes. So we need to make sure they have realistic expectations about what to expect. And we need to make sure they know when to reach out for support, not only for themselves, but for their loved ones. When is a crisis time? When do they need to call for backup? Versus when is this part of the disease process and okay? And then at the population level, what we need to do is we need to make sure there's enough providers to provide this mental health care. Providers we're probably okay with. What we're not okay with is the number of hospital beds that are necessary. We need to ensure that we're using state-of-the-art treatments. We need to ensure that policies supporting parity are maintained. This is something that could really be in jeopardy in the next couple of years if the ACAs continue to be dismantled. And we need to support research for treatment options. Like I just said, I can't cure schizophrenia. Does that mean that we will never be able to cure schizophrenia? No. We're working towards that. But we're not there yet, so the research has to continue. So here are just some of the additional references in addition to your book that I used. Okay, so you don't need to do anything with this slide. I just like to put them there in case people want to use something for something else or another class. Is there any questions for me? Okay guys, have a great day. I'll see you next week.